Good evening, everybody. This evening, we're going to talk about demystifying immediately sequential bilateral cataract surgery. A practical guide for beginners. My name is Christopher Liu, and I work from Brighton on the south coast of England. My declaration of interest: I am a proponent of safe, informed, immediately sequential bilateral cataract surgery. I may stand to benefit from referrals. I shall receive an honorarium for 4 hours of professional time from Bausch & Lomb. We're very thankful to Bausch & Lomb for this educational grant and putting this webinar on to demystify immediate sequential bilateral cataract surgery. It's an innovative way of delivering cataract surgery, and we're glad to receive this support. So we welcome some 240 delegates from all over the world, with the majority being UK surgeons. And I welcome my speakers, Steve Arshinoff, Björn Johansson, and Andy Cassels Brown. You will meet them in a few minutes' time. Now we do a poll. The question is, for each of you listening in and dialing in, I have a good understanding of all issues surrounding immediately sequential bilateral cataract surgery. You have to press the button yes or no on the next slide. And here we are. Can you please vote? Select yes, no, and then submit. So to our technician, how are we doing? Have many people voted yet? Because I cannot see the progress. Okay, so I will move on. Well, let me just vote myself. So here's the slide, and we can see that we have far more people who have said no, and just about 1/3 of people who've said yes. So that's good. We're not all beginners. So let me make an introduction before the speakers speak. I will touch on Rationale, the prerequisites for starting ISBCS, indication, contraindications, and measures to reduce risk of bilateral harm. Rationale. So we all know that a lot of eye surgery is done both eyes at the same sitting. So why not cataract surgery? Well, I think it's because cataract surgery used to be a lot riskier, but now it's very safe. So I think we can certainly consider it. The advantages of bilateral surgery, cataract surgery: one referral, one pre-assessment, one admission, with little time added for the second eye when the surgery is done. And there's always learning from the first eye, so the second eye may appear easier. If you need a general anesthetic, then only one is required, although the majority of immediate sequential bilateral cataract surgery is done under topical or subtenon anesthesia. There's only one post-op visit, one lot of waiting for refractive stability, one sight test, one new pair of glasses, no period of binocular imbalance or anisometropia whilst waiting for second eye surgery. And there is health economics, which you'll hear about. There are two disadvantages of bilateral cataract surgery on the same sitting. One is taking a risk with both eyes at the same sitting. And the other is post-op, there will be discomfort in both eyes during recovery rather than just one eye. What are the prerequisites before offering bilateral surgery? Well, of course, the patient needs to have bilaterally visually significant cataracts, and they should be in grown-ups. We're not talking about children or infants. There should be full informed consent, reliable biometry, good surgeon track record, and good team record with no new member of staff just joining without understanding how this works. Good hospital track record for endophthalmitis. There should be day one follow-up either in person or by telephone, and there should be a hospital hotline if there are any problems that patients wish to report post-op. The equipment and instruments should, of course, be well maintained and do not chop and change machines and IOLs whilst doing bilateral surgery, and beware of trialing new items as well. The measures to reduce risk. There are three things, really. Firstly, to exclude high-risk eyes until you feel more confident. Secondly, there is option not to proceed with the second eye if the first eye has not gone well. And then there are intricate measures to reduce the risk of bilateral infection and contamination. I will go through the details. Excluding high-risk eyes. These are eyes with higher risk of infection, corneal decompensation, lenticular abnormalities, and risk of glaucoma, retinal detachment, biometry error, and intraocular inflammation. On the last one, in particular, we have learned that BAME patients, so black and ethnic minority patients, have more inflammation and may not be so suitable for immediately sequential bilateral cataract surgery. So here are examples of the not so simple cataracts: small pupil, dense cataract, pseudoexfoliation, hypermature cataract, and so on. So the option of not to proceed with the second eye is we know that the risk of endophthalmitis and cystoid macular edema is increased by vitreous loss. So if your posterior capsule is bust, then don't operate on the second eye. And equally, it's the same with cystoid macular edema as well. Now, if thus it's immediate sequential bilateral cataract surgery and not bilateral simultaneous. There is always the option of not to go ahead with the second eye if the first has not gone swimmingly. Regarding reducing the risk of bilateral infection and contamination, the trick is very good draping and also treating the two operations as completely separate operations with different instruments and different chemicals and materials entering each eye. And of course, the importance of prophylactic cefuroxime. So here we are. I will introduce my first speaker, who is Steve Arshinoff, who will tell us about the outcomes comparing immediately sequential bilateral cataract surgery versus delayed sequential bilateral cataract surgery. Steve does not really need any introduction in this field, and he hails from Toronto and is speaking from Toronto this evening. Steve, please.
Okay, well, thanks very much, Christopher. So I want to take a bit of a different tact because I was probably the first one in the world to do routine bilateral cataract surgery in patients who just chose to undergo that in 1996. And so I'm going to talk about my own experience, global experience, national experience, and go back and forth. And I think the reason we're all here is because COVID-19 is an accelerator for everyone in the world to move towards bilateral cataract surgery. And so let's talk about it. First, I'll say that I have no relevant financial disclosures pertinent to bilateral surgery. I think it doesn't matter if you do one eye or two, the disclosure is the same. I'm also I'm not aware of any publication showing bilateral surgery to be worse than two unilateral procedures. And so when I think of why we perform immediately sequential bilateral cataract surgery, is because if you look at it in terms of all the issues, we find that it's better for the patient and it's really better for everybody concerned. And so why not do it? So when do you embark upon bilateral surgery? I think you should do this when every single step of your procedure has been perfected. You should be able to intracamerally dilate patients because some will come to the OR without good dilation and also know how to manage small pupils. You should understand OVDs and have more than one available to you for different kinds of problems. You should know your machines very well and the settings and be proficient. You should be good at IA. Your biometry should be reliable. You should use intracameral antibiotics, whether cefuroxime like in Europe or intracameral moxifloxacin like the rest of the world. And you should make sure your incisions are sealed and you have a consistent post-op eye drop and follow-up pattern that you're relying upon and you're quite good at and confident in. So I was the first in the world to publish a large series of bilateral cataract surgery done totally electively And in 2003, we published a series of 1,020 patients. And the interesting part of it was that we actually had fewer complications than we had in unilateral patients we were doing. And so I began to wonder why and published it and talked to people. And I rapidly found out that it wasn't just me, that the Finns were doing really elective bilateral cataract surgery since around 2002. Björn Johansson, whom you will hear from soon, published this article of a smaller series in Sweden just before my article, and he was also doing routine bilateral surgery. And in the Canary Islands, they were doing bilateral surgery, but chose to take their publication and not go to the medical journals, but to go to Parliament, because they had opposition in Spain, and they wanted Parliament to approve bilateral cataract surgery as being equally safe and effective as unilateral surgery. And in 2006, this was passed, and in Spain, it was the only country to approve bilateral surgery. So my own experience is I've done about 12,000 eyes. 80% of my cataract procedures since 1996 have been immediately sequential bilateral cataract surgery. I use intracameral antibiotics, which I think is critically important for every single case. Initially, we used vancomycin, but then it was genericized in Canada, and the cheap generic they made us buy caused TAS in many cases, and so we all stopped using it. And I was the first in the world to use intracameral Vigamox, and I now use 600 micrograms diluted in 0.4 cc. And in just under 10,000 consecutive cases, we've had 0 side effects and no infections with that dose. So that's what I propose to use. I'm taking part in many seminars, and one of the webinars I was involved in was in French, so probably most of the British didn't listen to it. And it was led by this group from Laval in Quebec City. And I found out that after I'd spoken to them in 2013, in 2016, they began to do routine bilateral cataract surgery, and by 2019, they were doing 60% of their cases bilateral cataract surgery. All 16 ophthalmologists doing cataract surgery at Laval University had converted to bilateral surgery, and they are now up to as many cases almost as I have done. Interestingly, they found the same infection rate that we found, that it's very low in bilateral cataract surgery. The infection rate for single eyes they found to be 1 in 14,500, and our bilateral surgery group found a few years earlier to be about 1 in 16,000. So we have a very, very low infection rate. But we weren't the first. It turns out that in 1747, Jacques Daviel was unhappy with the results he was getting from couching and converted to do extracapsular surgery, and actually did his cases as bilateral cataract surgery. And surprisingly, considering how bad couching was, he was very impressed with extracapsular surgery and decided that 88.5% of his cases were successful by doing extracapsular surgery bilaterally, which is unbelievably, incredibly good compared to the results with couching. So it was a huge step forward. We started our Society of Bilateral Cataract Surgeons, an international society, in 2008. We had 9 members only in the beginning. I think Björn took this picture, so he isn't here. There were 4 from Spain, 2 from the UK, 1 from Sweden, 1 Canadian, and 1 South African. And our society has been quite successful ever since. We have one rule in the society, and that is if you have an unresolved complication in the first eye, meaning a broken posterior capsule, dropped nucleus, something severe, you should defer the second eye. But if you merely have an errant anterior capsulotomy, but you complete the case okay, and the lens is in the bag, then it's fine to proceed. But we also found out that the best time to operate on the second eye is just after you finish the first eye, because every patient is a bit different. And we found that that's probably one of the reasons why we have such a low infection rate and low complication rate, because the second eye is always easier. So it's hard to discourage people from doing the second eye when it's always easier after having just done the first eye. But nevertheless, that's our general rule. A year after we started the society, we passed this document and we published it, Our General Principles of Excellence in Bilateral Cataract Surgery. I recommend that you all read this and follow it, because it's now become accepted as a global standard for how to do bilateral cataract surgery. And 2 of the things I want to point out, other than you've already heard from Christopher, is keeping everything separate and sterile, that you should make sure that you post the data in the operating room for right and left eye so everybody can see that and there are no mistakes. And then, somewhere I skipped a slide. And then the staff should be trained on biometry so that they see what you're doing and they pass the lens knowing what lens you're getting and never hand you the wrong one. By doing those, I have never put, or I haven't yet put the wrong lens in anybody's eye in the last 25 years. So it works. I was involved in many debates and discussions about bilateral surgery because the world first was opposed to it, and I was asked by both the ASCRS and ESCRS to take part in big debates in 2014, and I was very surprised because I expected to have a lot of opposition. And my opponent at the ASCRS was Kent Syverson, who surprisingly, because I had been to Colorado in 2003 and talked to their group, but they hadn't told me they began doing bilateral cataract surgery. And just before this debate, a year before, they had converted over to bilateral surgery. And instead of him criticizing me, he was said that now up to 80% of their patients were choosing to undergo bilateral surgery electively. So that was a very positive experience. At the ESCRS, I knew that many Spanish doctors, except for those in the Canary Islands, were opposed to bilateral surgery. And Jose Guel, who was not doing bilateral surgery, was my opponent. And he went through all the literature and tried to find articles showing bilateral surgery was worse, and he couldn't find any. So in the end of his discussion, he merely said that the main problem with bilateral cataract surgery is it may trivialize cataract surgery at a time when people already think that ophthalmologists are doing trivial work. But that, I think, is not a reason for us to not progress because patients may trivialize it. When I came back from there, I was invited to New York to meet this group who wanted to do small incision cataract surgery in sub-Saharan Africa and in some parts of India. And they had extremely organized or manufacturing case carts in the United States so they could do one complete case with all disposable instruments for $50. And it was a very impressive effort. I understand that they're doing very well in the outreach programs that they have developed. And they're now, I think, have done close to 1 million cataract surgeries. And then there were arguments in the U.S. about it because of the cost and not being reimbursed in the U.S. And this group in West Texas, interestingly, the sons of a classmate of mine from medical school, Avery Rush, were all doing bilateral surgery. And they figured out a way to only have 20% reduction in reimbursement in the U.S., whereas the increase in efficiency was 15%. So it really made very little difference, and they were the first proponents in the U.S. of doing bilateral cataract surgery. So what I want to tell you, if you're going to embark upon this, is you get some really rewarding experiences. And among those are amblyopic eyes. I used to not do amblyopic eyes, as many of us don't. And then many patients said to me, well, I'm concerned that my other eye is +5, my angle's narrow in the eye that you're not fixing. Why don't you just fix the other eye? So I began to fix amblyopic eyes, and now having done close to 100, have found that they see remarkably well. And often once you correct the optics of their eye, within a year, they're seeing like 20/30, 20/40, 20/50. And they're really extremely happy. And when you do patients like these who have various disabilities, either psychiatric, disabled, or dementia, their families are extremely happy that they can function better. This person, Christopher, who consented for his picture and to be a star for my lectures, has Duchenne dystrophy and for better or for worse lived to be almost 30, but he couldn't see because of his cataracts. And you can't move him from this chair because his bones fracture. So they have a special lift to take him. It takes a half an hour to reposition him. And we did him with one eye focused for far and one eye for close so he could read his iPad. And he was 20/20 for far and close the next day, and he was ecstatic. And his parents had driven him 400 miles for me to do his surgery. I also do many anesthetic class 4 patients, people that are waiting, unfortunately, moribund from terminal cancer, but can't see because of their cataracts, and previously were ignored. Their families asked me to fix them, and I've done a lot of these people, and they're extremely happy to be able to at least read and watch television for the last 6 months of their life. The same thing with positioning problems. So difficult cases are often the ones you're most proud of. I mentioned before about being careful, and we post this in the operating room for all the nurses to see, which lists every patient and how astigmatic they are, which eye we chose to have which lens of power. But this I post myself. I write for each patient on a little card, and I put on the microscope. And that tells me exactly what they're going to hand me. And the nurses are taught that the circulator calls out the lens power of the patient, the eye, as she passes it to the scrub nurse, who then calls it out loud again as she passes it to me. So there are no mistakes that way, and it's much more careful. And the surgeries are done as 2 completely independent procedures, which makes them much safer. Be suspicious of myths that you hear, because people will tell you all kinds of scary things about bilateral surgery which just aren't true. So one of them is the risk of bilateral endophthalmitis. Well, the risk of endophthalmitis in a study we did in our society with 125,000 eyes was about 1 in 17,000. And we had no cases of bilateral endophthalmitis, but the risk, if you calculate it, ends up being about 1 in 300 million, or a bit more than that, which means that if you follow our guidelines, the risk of having an infected case with bilateral infections is about one per patient every 30 years in the whole world. It's not very many. And then we always hear about improved refractive results achieved by modifying the IOL choice for the second eye after the first eye is done. It turns out it's not true. And if you use a new biometry instrument, a lens star, IOL master, new equations, topography, you're going to end up that you've never changed a lens or have to modify anything. I haven't done anything to anybody in the last 20 years since we had IOL masters, and I think it's just a non-issue these days. So, catastrophic complications. Well, when we do post-op bilateral ISBCS, we get about a 1 in 14 to 1 in 18,000 risk of unilateral infections. But with single eye surgery, the reported best rates around the world are 1 in 5,000. And I think we do better because the second eye is always easier. And people are always more careful when you do both eyes in their surgery. And bilateral infections, the risk is like 1 in 200 million, which is not particularly high. There have been 8 cases reported around the world of bilateral post-op endophthalmitis. In every case, they had a very serious breach of sterility in doing their surgery. So we can't count those. There hasn't been a single case reported when the principles were followed. For respect to TAS, there are no cases reported in bilateral surgery because people are careful in not changing things in their operating room. And CME, it's extremely rare or zero if you follow the principles and you give people drugs post-op or treatment during surgery to make sure the eyes aren't inflamed. Next pearl is, if you're going to discuss bilateral surgery, please use a terminology that we have settled upon. That is the accepted terminology in the world. I'm often asked to review papers on bilateral cataract surgery, and you read the paper and you can't tell what they're talking about because they chose their own terminology, and it's basically meaningless because we can't follow it without asking the authors. I want to quote 2 really excellent comments from people who gave talks at our meetings, and one of them was John Bolger in 2008, and I will just paraphrase what he said. He said that in London, where he lives, there's a risk of dying in traffic accidents. And if you look at the extra time in driving needed by a patient to come for 2 separate procedures, the chance of dying in a car accident is 3 times higher than a chance of having a bilateral infection with bilateral cataract surgery. And then Olivia Lee wrote an editorial in the AJO in 2014 saying that the risk of bilateral infections with bilateral surgery is 1/2000th the risk of death from general anesthesia. So again, it's not a significant risk. It might happen, but not likely. So the rationale for bilateral surgery is we fix the visual system, not one peripheral receptor. It's better for the patient, it's better for the family, and it's better for society and for the insurer. Now, there are many people now rushing to do bilateral surgery because of extra cleaning requirements from COVID-19. And they say they can do more cases, so they want to do bilateral surgery. So I want to look at that a bit because I was the first in the world to write papers on the cost of bilateral versus unilateral surgery, and here are some of the papers that I wrote. But I have one comment. We have to look at money versus ethics. So I think it is appropriate for us to study the comparative costing and reimbursements for bilateral versus unilateral surgery in every jurisdiction where you happen to be practicing. I think it's inappropriate and perhaps unethical to choose to do bilateral or unilateral surgery because you get paid more for one procedure rather than the other. I also think it's most appropriate for us to lobby jurisdictions to fund surgery equally and fairly so that whether you choose to do bilateral or unilateral surgery for the patient's benefit, you're paid equally. So that's my comment summary on money. Conclusions. If you want to find our guidelines, you can find them either on the ISBCS.org or you can find them on the Eye Foundation of Canada website, and it's being kept there. Bilateral surgery is now rapidly increasing around the world, spurred on by COVID-19. Please follow our principles of excellence if you want to do bilateral cataract surgery, because we've shown around the world that you will do much better doing that. And the reasons for opposing bilateral surgery haven't been verified anywhere in the world. The risk of bilateral infection is not high if you follow our principles, and the adjustment of IOL power for the second eye is also not a reality if you use modern machines. Money is the real issue, and COVID-19 is pushing people to look at doing bilateral surgery. Thank you very much. Okay, I'm finished.
Yes, and the next speaker is Björn Johansson. I'm talking here. There is nothing to say in between talks, I expect. So I just carry on here and say good afternoon, everybody, and thank you for the invitation to be here. It's an amazing event, I believe. I started learning cataract surgery in 1990, some years before Steve started to do bilateral surgeries. And my first operation was an intracap cryo extraction, leaving the patient aphakic, but satisfied nonetheless. 4 years later, I transitioned from ECC and IOL implantation to phacoemulsification, and presently I'm using 1.8 millimeter microincision cataract surgery in my regular programs. And this is my financial disclosure. I got fees from every party here except from the ISBCS. I will share some aspects of local and national experiences of ISBCS and the development in Sweden last 20 years. First from Linköping and then in general from Sweden, which is a lovely country, as you know. Some thoughts about starting ISBCS. I remember well the time when we took off, and I will look briefly at financing as well as consent procedure and refraction planning from my Swedish perspective. So there's a lot to get through here, but the financing issues are, of course, very important when you decided that ISBCS is the path to follow. We started in Linköping year after 98. 98, my senior colleague Björn Lund took part in a multifocal IOL study. And as the study protocol stated, bilateral surgery with as short interval as possible. He scheduled his patients for both operations during the same day. So 10 ISBCS cases were performed uneventfully. When I learned about that, I suggested, due to our more than year-long waiting lists for cataract surgery at that time, that patients should be given this option as long as we could keep safety good. And we presented our first cases. We learned from colleagues that, in fact, ISBCS was performed by other clinics, but this topic was not to be spoken of publicly, as one president of the Swedish Ophthalmological Society told me at one congress. However, nevertheless, we published clinical papers, as Steve mentioned before, and the British Journal of Ophthalmology was the first journal to accept a clinical follow-up study on ISBCS with modern technique in the beginning of 2003. And we also looked at the refractive outcomes after our first cases. When we started, it was easy to find patients in our long waiting lists that had disturbing bilateral moderate cataract in both eyes, without any complicating factors or other concerns. An optimal scenario for the beginning ISBCS team. The first cases were operated in one eye, then transported out to the waiting room, and another patient had surgery before second eye's operation. While logistics was disturbed, I believe this helped surgeon and staff to keep in mind the necessary total separation between surgeries, which is one central part of the guidelines that Steve talked about before. We even used different phaco machines for right and left eye, but after process review, we clearly established that only single-use material and fluids comes into contact with the patient. So we used the same machine after some months. And we made around 5 to 10% of our patients during the first years. Initial reactions were overall positive, including a patient that called the local newspaper. Her cataract had made her vision go down to 0.4 in both eyes, but she had stopped inviting her friends for coffee because she couldn't pour safely the cups. She couldn't differ between clubs and spades, I think it's called, when you are playing cards. So she quit her bridge society. And she went home after cataract surgery and started taking up all her activities again, including handiwork craft, as you can see on the image. Complications appeared nonetheless, and in fact, we reported in our publication 2 cases of unilateral endophthalmitis. This was before we, as last clinic in Sweden, introduced intracameral cefuroxime for all cataract cases. But we also had other bilateral complications, as you can see. Presently, ISBCS operations are done in up to 14% of our patients. This slide is unfortunately suffering from bad mathematics. We allow surgeons with more than 3 years continuous experience to do routine ISBCS, as National Cataract Register data suggests that complication rate usually stabilizes on a low level after 3 years of continuous experience. However, under supervision, trainees may well be allowed to do one of the 2 eyes after thorough information to the patient, and of course with a supervisor and surgeon at the first eye present. Cases scheduled for first eye surgery only may sometimes request or be offered to have also the second cataract operated the same day. And I do this around 2-3 times per week at normal programs. Obviously, a brief but comprehensive and balanced information to these patients is necessary, and usually the wording is something like this: complication may happen, but a complication after uneventful operations that threatens vision appears in around 1 in 1,000 cases. And this risk is the same for both eyes. So risk is not zero, but you balance this against needing the need for more visits and the COVID situation, etc. And there is no demand for written informed consent in Sweden in medical healthcare, although we use it in some instances. So Sweden is a very long country divided into several regions and county councils, all with their local parliaments. Thus, reimbursement systems and the different population patterns makes ISBCS penetration very variable between regions. Everything from no payment for a second surgery in the other eye the same day to 100% reimbursement can be found. When I worked at St. Erik's Hospital in Stockholm 8 years ago, we made a deal with a local county council to move from zero payment to at least 80% reimbursement for second procedure. So you can talk to those people and change things. And since 2019, I'm a member of a national work group working to equalize how patients are treated for their cataract in Sweden, independently of where they live. And to make the implementation of ISBCS equal in different regions is one important part of this work. So the red columns in this graph shows how the number of cataract surgeries in Sweden since 2002 has grown from around 75,000 to more than 120,000 per year in 2017. The data are from the National Cataract Register, which covers around 96% of all surgeries performed in Sweden. And the blue dotted line here, it's not so very well visible, but I hope you can see it, shows that the percentage of cases done as ISBCS rising from 4% to 15% during the same period of time. And of course, in absolute numbers, this rise is even more prominent. And this is as private clinic are doing more than half of all Swedish cataract surgeries in some years. And most of those surgeries are paid by public means after agreements with local county council parliaments. And some of those private clinics have used ISBCS in more than 50% of cases. And this graph is shown with permission from my co-authors Per Montan and Emma Freeling, as it is part of a paper being submitted for publication shortly. And I will share something else which will be published in that paper. And sensitive persons, please look away. We had some years ago a case with a bilateral postoperative endophthalmitis, and I will give you the details here in this session. This patient had a strong wish for bilateral surgery as she was very weak and found traveling outside her home for elderly very difficult. Accompanying staff confirmed that the patient probably would not accept more than one visit for surgery. After a normal 1 week postoperative follow-up visit, she developed coagulase negative Staphylococcus endophthalmitis in both eyes. And after treatment, vision improved, but sadly she passed away shortly thereafter, and an autopsy was not performed. We have gone through this case and we found no breaches of sterility and separation procedures. We know that patients over 85 are more prone to infection, and tragic as this case is, one may speculate that if one eye had been operated with the same complication, her history might have looked similar in many ways. Swedish medical legal cases, there are no ISBCS related, but there is one case with a retinal detachment in a myopic eye shortly after bilateral refractive lens exchange. And the ruling was that operation on the lens in both eyes at the same day is not a fault considering present methodologies, safety outcomes. And complications do occur, but it is no fault to perform the procedure on the same day. And it's the same surgical method for refractive lens exchange in high ametropia as for cataract. So with more than 60,000 ISBCS cases in National Cataract Register database, we still wait for the first medical legal case to appear. But annually, we have several medical legal cases after unilateral cataract surgery. Recording biometry, as Steve mentioned, optical and immersion ultrasound biometry are precise enough with the modern formulae. Patients with refractive surprises, as we found in our publication 2004, usually perceive no problems due to their clear media and similar deviation from planned refraction in both eyes. And refractive adjustment is meaningful only if the refractive surprise strikes the first eye and not the second. And as item 2, if the 0.5 diopter interval between IOL powers allow changed outcome with changed IOL choice. So careful counseling is of course necessary in cases where the preoperative planning of postoperative refraction is challenged. Talking about challenges, to sum up, there is a challenge when introducing ISBCS in the present situation, as many clinics may consider the approach. So it's about how to safely start this clinical pathway with staff that has not been using it previously. Education and successive introduction are important. And with ISBCS, I am usually saying that it's more important to avoid a disaster than to achieve a perfect, successful outcome. So start with straightforward cases, and with time, experience will make surgeons more confident and perform ISBCS when benefit outweigh risks, even with other ocular conditions, etc. So financing is an issue, and the solution depends on existing system. But in my opinion, ISBCS is a procedure that requires high quality in every aspect of the medical and clinical care, and therefore total reimbursement for 2 bilateral surgeries the same day should be higher than 200% of a unilateral surgery. In real life, this is not so, but I would go halfway and suggest that we meet so each cataract operation is 100% reimbursed. And with this image of the place where I prepared for this meeting, I thank you for your attention. And I guess it's over to you now, Andy.
Thank you very much indeed. I'm hoping you're able to hear me. I've been having a few signal problems, but...
Okay, so we move on to Andy.
Right. Can you hear me, Chris and team?
Yes, we can hear you.
Can you hear me?
Yes, we can.
Okay, thank you very much indeed. Lovely, thank you. So, good evening, everybody. It's been very interesting to hear the extensive experience of the 2 and 3 previous speakers. I'm very much still on my early learning curve for ISBCS, and we've been fortunate that it was about 3 years ago that the National Institute for Clinical Excellence, working with the Royal College of Ophthalmologists, felt it appropriate to approve ISBCS as part of the options that we can offer in the UK as part of the Cataract adult surgical guidelines. And so it was really, once we've had it approved by a national body like that, and since then it's been explored and particularly recently encouraged for consideration by both the Royal College of Ophthalmologists and UKISS, the United Kingdom and Irish Cataract and Refractive Society. So I've really been working mainly up on Orkney, which is an island, or a set of islands, an archipelago up off the north of Scotland, with a population of about 25,000 people. And that's very much in Scotland. We are able to do bilateral cataract surgery because we are funded to do it. Whereas in other parts of the UK, we've not been able to achieve that status yet. So why would one want to do ISBCS on Orkney Islands? I would say it's for the same reasons that you'd probably want to do it in most places in the world where you've got good quality control and particularly good infection control. As we've heard before, patients like it. They get more vision for less travel. There's less exposure to C19 in these recent times, and there's less anxiety generally every time they have to be going on a waiting list and coming into hospital with all the unpredictability of that. The clinical teams so far really seem to have liked it. The fact that we are now having less patients on the operating lists make things much calmer all round. We're doing more cases per operating list, so the productivity is increased. The communities are liking it because, as a result, the waiting times for cataract surgery are going down. One of the things I'm going to be talking about is it's not just patients and clinical clinicians, it's also that the planet likes it. There's much less carbon footprint, as we'll be exploring in a short while. And the hospitals like it. This is an image of the New Balfour Hospital on the island of the main island of Orkney itself in Kirkwall. But the COVID-19 hates it because it's got less contact time and less chance for it to get contact with us. So I've done about 100, just over 100, and so I still think I'm on the early learning curve, and we've done about over 100 in about 24 months. And as you hear the previous speakers, I started on those cases where I knew there was going to be significant planned anisometropia, the high myopes, or the high hypermetropes. But I also started with people where both eyes were failing the DVLA driving standard, legal standard of less than 6/12. And we did an initial audit after about 30 plus cases, and both the clinical team and the patient seemed to be very happy. So now ISBCS is the treatment of choice where patients have bilateral cataract symptoms. And I'm still at the stage where I prefer not to do ISBCS where a patient has established diabetic maculopathy or glaucoma. I know other surgeons are happy to do that. More recently, I reckon about 5 to 10% decline bilateral surgery. And we have now got a multidisciplinary team with an optometrist as well as a GP with special interest in ophthalmology also consenting. But in fact, quite a few of these reversed their decision whilst they're on the waiting list, and I suspect this is because the community is now hearing that it's a good thing to get them both done. I've only cancelled 2 patients on the day for systemic reasons, blood pressure and blood sugar control. 2 patients decided not to go on. One decided not to have their second eye done on the table. The first eye went very nicely, but the patient was very anxious indeed before we started. And when I said now everything's gone beautifully, would you like us to get on to move on to the next one? She said, no, thank you. I'm very, very pleased, and I think I'll stop there. Thank you. So the other patient I didn't proceed the second eye on had some corneal thinning on both eyes superiorly. In fact, after I'd done the first eye, I had to suture the wound and felt that let's postpone the second eye surgery. So this was our initial audit that we did back in May. We don't have an electronic patient record. It's fairly remote and rural. But we had 34 patients with 68 eyes. There were no operative complications. I was pleased that the visual acuities were achieving World College of Ophthalmologists guidelines. We only had one eye with a biometry error. We basically had one patient postoperatively who had a mild unilateral cystoid macular edema, but they've recovered and now routinely use topical steroidals on both eyes from the day of surgery. We had an independent audit done of patient satisfaction, and the results were all very encouraging. So we've kept going, and we've done 102 patients now. We've had no operative complications. I think particularly this is relevant in this most recent time of the COVID era. So I was fortunate enough with Orkney, we've had very few infections, and the Public Health Orkney consultant declared it as a non-continuous transmission zone, which meant that we were able to restart elective care and cataract care with a bit of a campaign, whilst all the other surgical specialties were unable or felt unable to start. I managed to encourage people to think, well, we're ambulatory, fit, healthy patients. We don't require an anaesthetist. We don't require wards, etc. And so Orkney said, yes, let's see how we get on. So we managed to do 109 eyes over about a month. And we had 32 of those patients were bilateral. We had on the first operating list, which was literally the first operating list that had gone on for about 3 months, we were allowed to have 4 patients on the list, but as it turned out, 3 of them were bilateral. So for 4 patients, we did 7 cases. And then we'd already said that if that goes well, we'll put the number of patients up to 6, which we did for another 2 weeks or so. And quite a few of those eyes were coming through as bilateral as well. Then when we had some of our accommodation returned back to us, having been repurposed for the COVID intensive care unit, we then went up to 8 patients or anything up to 10 or 12 eyes. So all patients had consenting and a COVID testing. We didn't have any complications, and we even got as far as training one of the other consultants to start doing some bilateral as well. Just going to talk a little bit more about carbon footprinting and the value of ISBCSC for the environment. And this is courtesy of one of my NHS Highland colleagues, Andy Pyatt, who's been doing some ISBCSC. These are, in fact, the Western Isles, off the western aspect of Scotland. I think you can see that the surgery is done in the capital, in Stornoway, and you can see that patients come a variety of ways through ferries and planes. I'm sure Björn has had a similar experience. And even if you just look at the mainland, Raigmore Hospital is in Inverness here, but you can see it takes a long time for these patients to get to any of these either sort of secondary care centres. So let's just look at what the carbon footprint is, what the savings just on travel. This isn't the carbon footprint related to the day of surgery. This is literally just on travel. Looking at 14 patients who had bilateral surgery from the Highlands and the Islands, we can actually see that between the cars and the ferries and the planes, and 4 of these patients, by the way, lived very closely to the central hospital in Inverness at Raigmore. That total of 14 patients had a total of 718 kilograms of CO2 equivalent. So whilst cataract surgery itself is quite a carbon footprint, the travel to and back from, and also for the refraction, etc., also has a significant carbon footprint. So one of the things I've been working on with colleagues is the new web app software tool, which is called iEfficiency, which not only has a time and motion study, which allows you to compare your productivity, your throughput, the number of cases you're doing on your operating lists, but it also allows you to look at some other aspects. But right now, I think everybody who's restarting post-COVID will be starting with fewer cases on the list. They'll probably have some accommodation challenges around social distancing. So most units will be doing less operating lists, and it's about this eye efficiency and time and motion study softwares will help you see where you're spending your time. In fact, I think before COVID came along, I even got as far as to say it'll show you where you're wasting your time. We know from using eye efficiency and time and motion studies, we spend a terrific amount of time turning patients around. The picture on the right-hand side is a screenshot from the eye efficiency from a mobile phone. And you can see that one of the options here is to click on the bilateral cataract surgery option. So we can start collecting data on productivity for bilaterals as well. We can also, if you want to enter all the relevant data to carbon emissions and cost per case, we can also calculate that as well. And we've recently added in some COVID data capture points as well, so that we can monitor and benchmark COVID activity as well, or COVID contact points, should I say. So just in my last two slides, I wanted to talk a little bit about the ethics, because I think people in the UK are still concerned, and I understand that, because it is very nerve-wracking when you first start out. But I'm afraid I think we're at the stage, particularly listening to the previous speakers and looking at all the systematic review evidence for ISBCS, I think patients should really now be given informed choice, even though the local eye unit doesn't actually provide it. We have been encouraged to give informed choice around the availability of multifocal intraocular lenses, which in the UK are almost exclusively available in the private market only. In the NHS, we're still encouraged to give the patients that information. And I personally feel it's now time, the NHS in the UK, to start letting patients know, not just that there is a possibility of having them done at the same time, but that this also might reduce their risk from COVID going forward as well. I think it's really up to the NHS and the public health commissioners and providers. We need to adapt and start offering and providing ISBCS across the whole of the UK, not just in Scotland. And I think we've got to a stage where the whole thing is rather illogical and it's unaffordable inequity. I think really ISBCS improves productivity, costs, carbon footprint, and the COVID risk. I really think we should be moving on to offering this, and I think we need to be working on the funding streams. I also think that industry as well, our colleagues must also support ISBCS and COVID risk mitigation and other environmental sustainability challenges, including climate change. And finally, I'd just like to do some acknowledgements. I'd like to acknowledge all those international colleagues who have, in fact, helped develop ISBCS. And as Steve pointed out, there's been quite a lot of work done in different places in low and income settings. And Professor Hannah Farr was telling me the other day that it was decades ago she was doing bilateral advanced and white mature cataracts in Gambia, otherwise they'd never see the patients again. Interesting to note that ISBCS actually ceased to exist in January this year, as that they felt that their mission had been fulfilled, no longer needing to prove the point. And we've got IEPB climate working groups and IEPB COVID restarts. I think we need to be considering all of these factors around ISBCS. Our UK colleagues have already identified, and both Chris and myself in Brighton and Leeds have been able to encourage and working with our Leeds colleagues to encourage the commissioning groups to fund ISBCSC. And the Scottish group have been very proactive. The Centre for Sustainable Healthcare in Oxford have been working with us to develop our efficiency. I'd like to acknowledge my colleagues at the Fred Hollows Foundation in Australia, their global partners as well, and we're looking at improving productivity and considering eye efficiency. And of course, finally, our colleagues at Bausch & Lomb, with whom I have no conflicts of interest, by the way, who've been supporting various strands along the way. So thank you very much for your time.
Thank you. So here we are, we've had our three speakers, and it's now time to have questions and answers and group discussion. We've had a number of questions. Firstly, let me ask my speakers whether they would have immediately sequential bilateral cataract surgery when they come to have cataract surgery. How about asking Steve first?
Absolutely. And I would do it with a femtosecond laser.
You're muted, Steve.
Oh, I'm sorry. I thought I'm on.
I can hear Steve, so
I should be.
Oh,
I
sorry,
think I'm
yeah.
on. Yeah.
Yeah.
I would absolutely.
please carry
I would
on.
also. Can you hear me now?
Yeah.
Chris? Okay, I would do it
I can.
absolutely. And I would also have it done with a femtosecond laser, which is, I mean, another issue, but that's how I would do it. We've done a lot of ISBCS cases with the femto laser, and it's just less inflammation, less everything. The patients do better. And particularly if you have like dense lenses, pseudo exfoliation, patients that were at all difficult with phaco, a lot of them do better with femto. The problem with femto has had is people look at broad groups, and so they mix all the regular cases with the difficult ones. If you look at them with regard to how much difficulty you expect with the phaco, you find out that the femtos are better for those cases. Anyway, it's another issue, but I would definitely have bilateral cataract surgery.
Thank you. Thank you. So let's ask Björn. Björn, would you have bilateral cataract surgery when the time comes?
yes, I would, and I suggest this also to people who are near to me or that I am in a special relation with in work, etc. So there is no exceptions. ISBCS is the way to go if you have a symptomatic cataract in both eyes.
Yeah, I agree, Björn.
Andy,
way,
how about
Chris,
you?
Yes, I would most certainly have ISBCS, and if we're allowed an additional opportunity, I'd probably go for bilateral multifocal intraocular lenses as well.
Okay, well, I can tell you I will also have bilateral on the same day, but I'm not going to tell you which surgeon I'm going to choose. I will tell you, however, I'm going to have a general anesthetic because I don't really like seeing things coming close to my eyes. Now, there is another question, and that is, which eye do you do first, and which eye do you pad, and which eye do they see through post-op? So let's start with Steve then.
I always do the left eye first, and the reason for doing the left eye first, there are two reasons. One of them is in the way that our operating room is set up. The door is on the far right corner of the room, and it allows the staff to bring in things without interfering with the eye. I don't want it to go over to the right eye, to the left eye after the right eye has been done. And then I do it always the same eye first, because that way you reduce the risk of them giving you the wrong lens or anything else with your first and second eyes. My staff know the left eye is the first eye every single time.
Okay, Björn?
Well, my staff are more confused because I usually start with the worst eye first because I like to have an easy part left when the first eye is done. And in some instances, I start with the better eye if there is a smaller visual potential in the eye with more cataract. And if there is an amblyopia, I may also start with the eye with a better vision and then follow up with amblyopic eye. So it's right eye or left eye. So they always ask, like we double check, as Steve says, with intraocular lens power, we double check which eye are we going to operate. And we also mark our patients on the skin with a 1 and 2. Before surgery. That's the surgeon's responsibility. So we use a lot of methods to double check and secure information between different stuff.
Andy?
Well, I'm like Björn. I always start with the worst eye. That seems to be what our patients would expect and would want us to do. In regards to the other comment about what pads and things, Immediately having done the first eye, I put a transparent shield over the eye just to protect that eye whilst I'm doing the second eye. But in fact, I don't use any pads or any shields. Straight after doing the second eye, I haven't used shields. I use topical intracameral anesthesia, and the patients just go straight off the table without any pads, without any shields. And they see. I kind of think the whole point is to give them good vision as soon as possible, and they're actually walking out of the room at the end of the self-theatre session. So that's my standard.
That's very good, Andy. I do the
okay,
same thing.
well, actually, I'll tell you what I do. And there are now just 5 questions coming in regarding type of anesthesia as well. So I'll mention that as well. I also mark 1 and 2, and I usually do the worst eye first, except when the worst eye is a much higher risk eye. Then in order to give them the best chance of having both eyes done, I do the easy one first. Now, in a routine case, the first eye would be topical and intracameral, and then they would get a Gelnet pad and shield. And the second eye, because patients always feel the second eye more, and they've already been on the table for a few minutes, the second eye actually, for me, gets a subtenons anesthetic, and it's a scleral tunnel as well to improve safety. Then when that's finished, then I put a pad on and a shield on, and then I take off the pad and replace the shield on the first eye so they can see. And the subtenons eye is undercover until the following morning. So we have other questions coming in. One is regarding remuneration. I think this is a big problem because if the hospital does 2 operations and only gets paid for 1, and for jurisdictions when the surgeon is paid per operation, then hospitals and surgeons are unlikely to be keen to be doing both at the same sitting if they stand to lose money. What is the solution then? Steve?
The solution is to lobby governments to change. Everywhere, people are penalized for the second eye, both the institution and the doctor. In Ontario, where I live, the institution, if it's a government system, is paid 0 for the second eye, and the doctor is paid 15% less. But also in Ontario, as of last year, more than half of the cataract cases are being done in private centers. And that's probably why, or one of the reasons why, because the government system just isn't working very well. So in a private center, yes, we can charge the patient a refractive surgery fee for whatever else we do, and that usually will cover the difference.
How about in Sweden? What happens? There are many, many areas with different jurisdictions.
Yes, and I believe it's important that surgeons work with their clinical boards and hospital boards and as well with politicians, because I have been through changes in political majority in some regions, and then the reimbursement changes. So we have a responsibility to really communicate why actually ISBCS should be paid more than 2 single surgeries, as I said in my talk. Yes, if they are squirming when they hear that, we can be kind and take it down to so that each cataract surgery should, of course, be paid the same amount of reimbursement, considering as well the large savings that the society makes outside the hospital system. Our county councils also run homes for elderly with staff that accompany patients. They run the public transports, etc. So there are a lot of savings made outside the hospital area. But in this situation that we are now, we need to have a broader perspective, and that we need to tell the decision makers regarding finances. That's my opinion.
But Björn, the hospital saves money too. They only register the patient once. So it actually costs them less per procedure doing both eyes.
Yeah,
in most jurisdictions, they don't get paid back for that, but they actually pay less with your 2 eyes.
Yeah, we save about 15% of the costs at the second ISBCS surgery. But then you should consider as well that this selection of patients, it has to be done with the highest quality. There shall be no flaws. And because of these demands, I think that you can claim that it should be at least the same price for cataract surgery, regardless of whether the other eye has been operated just before.
I agree.
Andy, do you have anything to add before I sum up?
Well, just to say that in the UK, within the National Health Service, patients are not actually paying. So there's really no incentive for patients, surgeons, or hospitals. In fact, I would say it's the other way around. I think the incentive ideally should go that ISBCS should be freely available for all NHS patients. I think there's a whole lot of common sense in that, and we're just going to have to work with our commissioners. I think, Chris, you're in Brighton, you've had negotiations, and my colleagues and I have also negotiated with our commissioners, the cataract funders in Leeds. What they said is that, okay, well, please go ahead and we will reimburse you either 2 or 1.8 times the price of one if you do both eyes, but we would like to share the savings, which I think is a perfectly reasonable approach to take for commissioners. No reason why hospitals or surgeons should get all the money. It's a public health system. Let's all be sharing some of the savings. So I think we've got quite a bit of work to do with that within the National Health Service in the UK.
Absolutely.
Before we can get that approved.
Yes, so the savings should be shared because then the money can be used to benefit other patients. So I will sum up because we're running a few minutes late. Thank you to all my speakers. So summing up, ISBCS is a valid and highly efficient method of delivery of cataract surgery to adult patients with bilateral visually significant cataracts. I think we have seen that. And in terms of COVID-19, because of social distancing and antigen antibody tests and self-isolation and trying not to spread and catch the coronavirus, then the fewer hospital visits and the fewer patients at the hospital at any one time, the better. So the renaissance or propagation of ISBCS may be helped by COVID. There are nice guidance, which I will just briefly share with you in a second. We've talked about the prerequisites of surgeon track record, team track record, and hospital track record. And here are the 2 clauses from NICE 1.6.3 that we have to consider and offer. It says bilateral simultaneous, but I mean, that's a misnomer. It's actually bilateral sequential, of course. People who are at low risk of ocular complications during and after surgery, or people who need a high-risk general anesthetic. 1.6.4 discuss the potential risks and benefits of bilateral surgery with people, which should include the potential immediate visual improvement in both eyes, how it will not be possible to choose a different intraocular lens based on the outcome of the first eye, but we know that is not important with modern formulae. The risk of complications in both eyes during and after surgery that could cause long-term visual impairments. And we know that there is a small but definite risk of bilateral visual permanent sight loss. So that needs to be discussed with the patients and they need to sign along the dotted line in most countries. And of course, they will be more uncomfortable because both eyes would have had surgery. So to continue to sum up, informed consent and keeping good records, very important, because if something should go wrong, you haven't done wrong by operating on both eyes at the same time if you followed all the protocol and done informed consent. However, if you don't have good records and the patient says something and you can't refute that because it's not in black and white, then you may be in trouble. So keep very good records. Autonomy is one of the 4 pillars of medical ethics. So patients should have a right to choose. And similarly, surgeons must offer so that patients can choose, but surgeons cannot be made to do something they don't want to do, but they should still offer the choice And if they don't feel comfortable, they can refer to a surgeon who does offer bilateral surgery. And we've discussed the protocol to reduce bilateral harm. It's difficult to quantify the risk of bilateral endophthalmitis, but it's exceedingly rare if the strict protocol is followed. Bilateral CMO is another problem, and some of it is non-resolving. So be careful of epiretinal membranes, and these need to be detected with macular OCT scans preoperatively. Biometry error, as long as you use optical biometry and good third-generation formulae, you're all right. There were questions about training, and because each eye should be considered individually, there's no reason why the second eye cannot be done by a more junior trainee, and both eyes can be done by a more senior trainee. People have also asked about the waiting list. The thing is, if you can do more eyes of fewer patients, yes, there will be an initial hump, but because they're not coming back for their second eyes, then the waiting list will actually shorten rather than lengthen. We've just discussed remuneration, and we've heard about carbon footprint and sustainability. So now I need to repeat this poll so as to find out whether your understanding you feel has improved. So the question was, and is again, I have a good understanding of all issues surrounding immediately sequential bilateral cataract surgery. I'll move on to the next slide, and you will choose the button yes or no, and then press the submit button. I'll give you some seconds to do this before we reveal the results. Are people voting? Oh, well, I think I thank my speakers. I think we have achieved something, so that's good. But what about those 6%? What are we going to do? Well, they can contact us by email, and they can ask questions, and I'm going to stay on and answer everybody's questions before I log off. Steve, there is a particular question for you from Shamina Khan on intracameral vancomycin. If you would answer that, please, on the Q&A. So today is my wedding anniversary. So I have to thank my wife for putting up with me doing this on our wedding anniversary from 24 years ago. But also I thank Björn for hosting the webinar, and the technicians who've been ferrying back and forth in the background. You don't see them, but they've been doing a lot in the background. I thank my three excellent speakers, Steve, Björn, and Andy. I thank you, the audience, for joining us and participating so actively. Now, the next thing is you do need to complete a feedback form with some questions in order to obtain the 1 CPD to be granted by the Royal College of Ophthalmologists.